we are going to go ahead and get started. Just a quick note real quick, this is being recorded. It'll be on YouTube later, but just on the Utica Park Clinic, we have our own YouTube site. It's really just so that other clinics can go back and access this later on, okay? You're not going to be on Facebook or anything like that. So, but we want to just be able to record what's going to be shown, so we have that resource available. But this is kind of the real kickoff on the DoNoHarm project with the opioid prescribing, and this is just very pertinent information. Obviously, this is a big problem nationwide, but it's in Oklahoma especially, and this is a great way for us to be evaluating as a practice and as providers. How are we really treating these patients? You know, there's good things to opioids, and there's a lot of bad things to opioids, and we want to make sure that we're finding the right way to prescribe it and doing an evidence-based approach to that, so that it's not just, oh, I'm never going to prescribe that or whatever. We really just want to make sure we're doing it correctly and responsibly. So Dr. Duffy has been working on this for a while, and he's going to give us a little bit of a talk about it and go from there.
Thank you very much, Mark. I'm Dan Duffy. I'm a general internist by background. Have not been practicing for 4 years right now, I guess. But have been really deeply involved in this kind of continuing education. And that's what I think this is. It's actually formally called dissemination of new science and implementation of new processes in practice. And the topic of this one is addressing the opioid epidemic in primary care practices. So I'm going to have my team introduce themselves. It's getting bigger all the time. And this is the team, since we're close here in Owasso. A lot of people wanted to come to this academic detailer visit. And after we do that, I'm going to ask you all to introduce yourself and state what your role is in the practice and whether you are on the second floor practice or the third floor practice. Will that be okay? And we'll get down to business. So Jonathan, do you want to lead off?
Sure. Well, I'm a medical student in my 4th year at the OU Tulsa School of Community Medicine. I'm really here because I'm interested in the project and I want to see how academic detailing is done. I want to do this in my career.
Cheryl Critchley. I am from Mulkey County. I worked with OPHIC for going on 4 years now. We did the Healthy Hearts Project, and I was in charge of the southeast part of the state. I'm in charge of the pain management opioid project across the state now. The team of facilitators like Courtney, practice facilitators that go into your practice.
Barbara Norton, I'm a faculty member in Oklahoma City, so I made the drive. And I am here also as a learner and very interested in this model as it applies to future projects. And I work quite a bit with a group of patients that team up with residents and faculty on quality improvement. And so I'm very interested in how it might apply also in that context. So thank you for letting me be with you today.
And I am Courtney, so most of you have seen me. I will be the facilitator working with both clinics, 2nd and 3rd floors. So you'll see me a lot.
And I'm Karen Deals. I work here on the 3rd floor as a practitioner.
Terrific. Good to meet you, Karen.
I'm Chuck Tryon. I am the project manager at OPHIC, and I also carry a Utica Park badge because I work with Dr. Gallus and Dr. Callery a couple of times a week. So we've been working on projects here as well in pop health.
So you've heard this word OPHIC a couple of times. We live in acronym hell. And OPHIC means the Oklahoma Primary Healthcare Improvement Cooperative. OPHIC, terrible acronym and a terrible long name, but that's who actually runs this kind of activity. So
Nina, I work with Dr. Gallus, medical assistant on 3rd floor.
Terrific.
Your turn.
Oh, I'm Dr. Militia. This is my lunchtime.
And are you on the 2nd floor or 3rd floor?
3rd floor.
Yeah.
My name is Charlotte. I'm with Dr. Callery on the 2nd floor at the front desk.
Okay.
Laura Lee, DSR, 2nd floor.
I'm Barbara, 3rd floor, front office.
PSO.
I'm Jeanette. I'm a medical assistant working for Dr. Callery.
I'm Kim, and I'm currently the lead here on the 3rd floor.
Amanda McGuire, office manager.
Deb Lutz, medical assistant for Dr. Moneypenny and Dr. Holden on the third floor.
Cora, medical assistant for Dr. Marcy.
Hi, Connie Whittemore. I'm the office manager on the second floor.
So there's a separate office manager for each floor. Okay. We realize the office managers are the people that run the show. you make the doctors think they are, but nothing gets done to it. Yeah.
Oh, I already did. Yeah.
Oh, yeah.
I'm Tracy, RN care manager for second and third floors.
Okay. Have we heard you guys?
Yeah.
Yeah.
Okay, great.
Ashley, third floor care manager. Yeah. Samantha, MA for Jessica.
I'm Susie, I'm MA for Dr. Third floor.
I'm Debbie, MA, I'm Logan Family.
Okay.
Teresa, MA, third floor with Dr. Patterson.
Okay.
I'm Ashley, MA, third floor, Dr. Peterson.
So what I hear is each doctor has their own MA and a float. I heard that there's an office manager for each practice, and I heard that there are 2 care managers, one for each floor or shared among the, just doing care management wherever it's needed. Hi. Introduce yourself.
I'm Jessica. I'm a provider, nurse practitioner.
Okay.
Every practice.
2 nurse practitioners, and how about the clinicians?
Dr. Moneypenny.
Dr. Moneypenny? Glad we probably met you before, but I don't know. Okay. And Dr. Lucia introduced himself.
Dr. Patterson.
Dr. Patterson. And Dr. Colbert.
No.
An old friend of mine, long time ago. Better not tell her that. Okay, so what is the Pain and Opioid Management in Primary Care Project? You all have this handout in front of you. And the beacon light symbolizes the fact that this is a storm, and we need a light within the storm. If you go to the second page, there's nothing new on this page that you don't know and that isn't in the news. The big problem is Oklahoma is a high prescriber of opioids. Good news is, even over the past 3 years that we've been working in this and talking about it, the prescriptions for opioids and the dose of opioids in any given prescription has dropped pretty dramatically, and it's going to continue to drop. It was dropping well before the state law changed. The state law now makes it pretty difficult to give very high doses for any length of time for acute medications. If we look at the deaths related to opioids, you see the chart there that opioids account for the majority of prescription drug-related overdose deaths. It has been benzodiazepines at other times. Tricyclics even were a problem a long time ago. But you'll notice on this chart, look at the blue line at methamphetamines. And I think that's something we need to really pay close attention to. That as we drop in the opioid prescription deaths, we're beginning to see an increase in methamphetamines. And it isn't shown on here, but the heroin, particularly the synthetic heroin, is increasing as well. So, opioid prescriptions written for acute pain conditions frequently result in unused pills. And people are afraid to not hang on to them because they're going to have pain in the future, and they don't want to have to get them, so they keep the supply in the house, and that supply in the house is fair game for grandkids, for others. And one of the group of people that you all may not be aware of is all of the service people who come into a house. If they have a substance use problem, their first deal is to scour the house to pick up the unused meds. So, leftover prescribes increase the risk of addiction and accidental overdose. We all know, because of the state law, if we go to the next page, that we want to limit the opioid prescribing for acute pain. Most patients don't take the opioids that are prescribed for acute pain. We have a lot of women in the room. How many have had a C-section? How many opioid pills did you take following your C-section?
I didn't have any, I was on the morphine drug.
You didn't take that home with you, did you?
No, I did not take that home.
And what did you have at home?
Nothing.
Nothing. Anybody else? Anybody else have a C-section?
Can I also
Yeah.
add that when I had mine, when they disconnected me from the pump, the nurse told me that if they had been responsible for giving me the medication, they would have given me 25 times the amount I gave myself.
Isn't that interesting? That's the bottom line. People don't really use these or need them. If somebody really needs them, that's a red flag. That's a red flag. They either may be becoming addicted or they are already addicted. So what do we use? Non-drug approaches. If we're going to use drugs, acetaminophen is a remarkable analgesic. It's absolutely remarkable. And NSAIDs are really good for acute trauma or tissue injury, but acetaminophen are good for a pain at a time. Opioids, if required, and there are some serious injuries and so on that are going to require it. And my biggest fear in this new law is that we may undertreat some people not in denying them opioids. We've got to be careful of that. So the goal is to do no harm, provide a short course. People rarely need more than 3 days of an opioid. And I'm going to tell you my own story. I just had surgery on my ear and had an ear flap and had a basal cell carcinoma taken out. And the dermatologist who did this asked me, did I want any opioids and I might be in pain? And I said, well, maybe 2 or 3. I don't know what kind of pain I'm going to have. And I did know he was screwing around with the nerves there, and I didn't want a neuralgia. So he gave me 6, I think. And I took them home. I did not take a single one of them. I needed 2 Tylenol, and that was all I needed. But I kept the bottle. And I had a person who works in my house who has had in the past a problem with substance abuse. And he wrote me a very nice note, put the bottle on. He said, in my job, I do have to get Q-tips and other things out of this drawer. Please never, never keep this kind of medicine where I might come in contact with it, because this will not just harm me, but I can guarantee you will absolutely kill me. And I thought, wow, what a message I needed from somebody who is in recovery, is doing very well, but who knows full well that if the temptation is there, they doesn't help. Okay, but if we're prescribing opioids for patients who have acute pain and are on chronic pain medication, the goal is to make sure the right hand knows what the left hand is doing, because the acute pain medication may in fact interrupt a tapering that the primary prescriber is doing. For patients with acute pain requiring opioids who have an opioid use disorder or any substance use disorder, that's alcoholism or other drug use, it's important to collaborate with whomever is helping them with their other substance use disorder. Better said than done. That's really hard to do. Most patients who are in serious recovery will say, please don't give me any narcotics. I can get along without it. And actually, it's a good idea to know whether somebody has had a problem with drug addiction and are in recovery now. Okay, so if we move on to the next, which is transitioning from acute to chronic pain, this is where everybody on the staff needs to really be acutely aware of what's going on. So when we put this together, we said that when acute pain lasts beyond 90 days of the expected healing, the focus of care shifts to chronic pain management, and this includes closely assessing functional goals, optimizing additional non-drug and drug treatment options, and reduce risk of prescribing opioids. What we've learned over the past year of this particular project is that's very idealistic and has nothing to do with reality. The reality is that if somebody is picking up their second 7-day supply of an acute opioid, a bell should go off. Are they developing chronic pain? Number 2, if they pick up their third prescription of 7 days supply, so they had 1 7-day, second 7-day, the third, the law says you need to treat them as a chronic pain patient and get an opioid contract. that they know the risks. Look at that. That's 21 days of opioid therapy. 21 days of opioid therapy, a red light goes off and says, be very cautious. Most acute pains, now, are there some terrible vascular surgery? Of course there are. But most acute pains that we're going to see in our practices rarely need opioids for more than 21 days. So at 21 days, you may have passed over into a chronic pain syndrome. I'll talk about chronic pain syndrome in a minute because it's a very different disease than a broken leg. Very, very different than even an aneurysm resection or an open heart surgery. Very different disease. It isn't tissue damage per se. It's a chronic brain disease. Everybody hear that? Chronic pain is a chronic brain disease. It does not respond to opioids. In fact, it usually gets worse with opioids. Now, there are certain chronic pains we all deal with. For instance, and I'm not talking about the person who has intermittent migraines that are really severe and might have 3 or 4 a month, but are pain-free in between. I'm talking about the people who have chronic pain, chronic pain every day. Bottom line on this slide, we need to be careful that when we are progressing with refilling opioid prescriptions for more than 3 weeks, we need to be thinking, are we moving into this area of chronic pain? What do we do about that? We reassess it and begin to push, truly push, other non-opioid alternatives to pain. Let me stop. Any questions or comments anybody has? Do you have anything you want to say, or Mark? You guys all agree with this, or? I don't think I need to agree. Okay, so on this, the algorithm for managing chronic pain. Now we're into chronic pain. What do we know about chronic pain? It's not acute pain. It, in fact, is a chronic brain disease. And if they are currently taking opioids, go down the left-hand column where the yes is, assess their functional goal. So the most important thing about chronic pain is we never aim to cure the pain. What we aim to do is improve the function. Can people do what they need to do to live their lives maximally? Promising to cure the pain is a losing game in many circumstances. So we assess their functional goals, evaluate side effects that they may have, check the Oklahoma PMP, which will let us know, are they getting drugs elsewhere, are multiple prescribers, clues to addiction, screen for opioid misuse using a urine drug screen, and using ESPER, which is screening for depression, screening for other substance use disorders, and recommending treatment for that. And then add naloxone to the chronic pain treatment if they are taking an opioid dose of greater than, look at that number, 50 morphine milliequivalents. The more naloxone we can get out in the community, the more lives we're going to save. It may not be that patient or that patient's family, but it may be somebody. And then the goal is to taper to the lowest effective opioid dose. And that may take a year if somebody's on a dose of 80 morphine milliequivalents, 120 morphine milliequivalents. It may take a long time because guaranteed, once we start tapering, they're going to withdraw. The first symptom of withdrawal is anxiety, and the second symptom of withdrawal is pain and discomfort, and so they're going to want more. Okay, so we could keep going around, reassess, maximize the non-opioid treatment, and here's the case where the non-opioid treatments that work the best are actually cognitive behavioral therapy, mindfulness, and other psychiatric interventions are really very helpful. And do you have those available to you within this? You have a good pain management group.
We have a full-time behavioral health specialist that works in our pain management clinic, and they do some CBT, they do some mindfulness coaching. They really work with patients to try to minimize the complications of the opioids. And in those patients who are trying to wean off of opioids, they really help try to help manage that.
Terrific. Okay, so if they are not on opioids, the goal here is not to start it. Keep looking at the functional goal, continue that treatment. use non-opioid, maximize that. And if you can't, then a trial of opioids. Now, the thing that's come up is not a trial of long-term opioids, but people will have chronic painful conditions that actually are made up of exacerbations and remissions. And you all have, like I had, patients with chronic back pain, patients with chronic arthritis or other pains that are understandably tissue injury. They're going to have exacerbations when they have either acute injury or have overwork or something of that sort. For very short, treat them like acute painful episodes. For a very short period, a small dose of opioids may help them be more functional. And that's acceptable. But think of that not as chronic, treating chronic pain with a chronic opioid, but treating the intermittent exacerbations that commonly occur in opioid. Migraines. Opioids don't work. Use the migraine medicine. Fibromyalgia does not work. Opioids think fibromyalgia works. So moving on. Let's look at this box in the middle here that says assess progress of pain management with the PEG. Do you all use a standard pain assessment instrument in your practice?
Not yet.
Not yet. We recommend a PEG, and Courtney will be helping you work with EPIC, and I think EPIC has PEG in it. And PEG just means, instead of saying using the Happy Face scale that was invented at the Children's Medical Center right here in Tulsa, you know that? Instead of using that scale, which was used for kids and nurses, and then it got adopted by the JCO and we went crazy. What we do is 3 scales. We say, how much in the past, what is it, on a scale of 1 to 10, what number best describes your pain on average in the past week? So we're only looking at back a week, and we want to know from 0 to 10, what describes your pain, how severe your pain is. So P equals pain. What number best describes how, during the past week, pain has interfered with your enjoyment in life? That's the E in pain. And the G is, what number best describes how, during the past week, pain has interfered with your general activity? We add those 3 scores up, divide by 10, and come up with or divide by 3, and come up with a score. And it's just a little more accurate. It's been validated, and so on. We've talked about chronic pain, what works in chronic pain. Here's a chart you might reference, and we haven't provided the evidence here, but we basically pointed out that when it comes to neuropathic pain, lidocaine packs, selected SSRIs, tricyclic antidepressants, serotonin, norepinephrine, they've all been proven to work and work much better than opioids do. We have the non-drug therapies. Exercise works in nociceptive pain, and you can see that list right here. I think in some of our practices, this is hanging up in the doctor's office and makes the statement that opioids aren't on that list. The next page shows 2 kinds of structured visits. One is building a structured visit, and the way Jim Mold describes this is like the pregnancy or prenatal visit. You have a structured visit, you get something on the first visit, and then you have your monthly visit or every 2-week visit, whatever it is. And you do the same thing all the time. The staff is trained to do it. Most of it is done in the rooming process or elsewhere, and then the clinician comes in and simply makes the decision and moves forward. So in the initial visit, we do a comprehensive exam, evaluate the medical conditions, particularly sleep apnea is a dangerous one, screen for behavioral health problems, the SBIRT can do that, check the OKPMP, establish goals for better function, and create a multimodal pain plan. If an opioid is involved in that, we add the advice on the risk of opioids. The risk is greater than the benefit for chronic pain. Monitor for appropriate opioid use. That's checking the OKPMP at least every 3 months. Discuss the management of opioids. That is, store them in a safe, locked place. and refer or discuss co-management with appropriate specialists. And here we have our pain management specialist, but we also have our psychiatrists and behavioral health people. The last point, and we're not required to do this by law, is to have the patient sign an informed consent that says all of these things were discussed with them. And I think you have an informed consent that you have built in as well. The next box shows the follow-up, and for any patient on chronic opioids, the chronic follow-up should be at least every 90 days and should include the elements that we have listed here. And again, building that into your office routine and protocol. In fact, the new state law actually says we have to have a written protocol that basically says this. Most people have a written protocol they put in the drawer, but everybody in the staff needs to be trained. Here's something that can be converted into a poster. The guidelines, which are fairly complicated when written out, we've simplified to do no harm. Always assess pain, create a pain management plan, set goals for improved function, and recommend naloxone. More naloxone that's on the street, the more lives we're going to save. Do not prescribe opioids without an assessment plan, and do not prescribe sedating medications with opioids, and stop overdose deaths and no suicides. One of the things we're beginning to learn is a lot of the opioid overdose deaths actually are suicides. And so as we become more sophisticated in managing these situations, we begin to realize chronic pain overlaps depression, overlaps suicide, overlaps overdose. And that becomes a real dish until we get to know the patients and be constantly aware those four things would be going on all the time. Second things is there's addiction shifting. People who become dependent on on opioids or other drugs, if it's unavailable, will shift and become alcoholic or use alcohol, which is more readily available, or actually what's cheaper is methamphetamine and heroin. So we just have to be aware of that. I don't think you're going to see a great deal of that, but some. How do we reduce harm? We stop opioids or taper them. Oh, word about stopping. Do you ever just stop opioids? Yeah, maybe if it's 10 milligrams of hydrocodone twice a day, that may be to stop that, and they won't have any problem. But if somebody's up in the 150 morphine milliequivalents per day, it is cruel and unusual to stop that. And that also means don't discharge the patient from the practice saying you violated the agreement without getting them into a tapering program or getting them help that they need. We've seen, since this law was passed, dozens and dozens of hospitalizations for old people who have gotten heart failure and had COPD, had all kinds of problems, strokes, because they couldn't get their opioid. And they went into withdrawal and had seizures and so on. So harm reduction, drop the dose. If there are side effects or it's ineffective, if the person's developing an opioid use disorder, what do? We don't stop the opioids cold turkey, we get them into treatment. Now, nobody here has buprenorphine privileges. Probably something we're going to want to consider as we work over the year. Because buprenorphine is absolutely a terrific drug in that circumstance. It can help the patient get out of the risk of the high dose of opioid and begin to taper them. It's essential if they are on, if they have opioid use disorder. It truly is an essential treatment. Agree in writing, we've talked about that opioids have greater risk than benefit, that the patient's only going to use one prescriber and one pharmacy. We won't give early refills no matter what happened to them. Although we're not going to let you go into withdrawal. So now you have a delicate balance. How do we handle that? We will have monitoring visits, we will do random urine drug screening, and we'll check the PMP regularly. And it's the staff here who we want to know that urine drug screening, that regular PMP check, may become part of the rooming process, so that the clinician has all the information they need, just like the weight, blood pressure, temperature that you're going to have in the rooming. Use the lowest effective dose, use immediate release formulations. There is no place in our practices for no places in overstatement. There are very little places for long-acting opioids, the extended release opioids in our practices. Now, some of us are dealing with patients who have are at end of life, have palliative care. None of these guidelines apply in that situation. We need to make sure that people are as comfortable as they can be at end of life. Acute pain, usually less than 3 days, rarely 7 are needed. Chronic pain, keep it below 15 morphine milliequivalents per dose. And we want to monitor the progress toward functional goals, monitor for misuse. Aberrant behavior is that patient that comes in having all kinds of excuses as to why they need the opioid and why they, and particularly this is patients who are new to the practice or a group who are shopping. But you probably have a reputation in Owasso that this is not an opioid shopping friendly practice. Okay. And the key messages are there. I won't go over those. Last statement on the back is store opioids in a safe, locked place, throw away unused prescriptions. And I was surprised to learn this, but the who published this, all of the things we use as opioids are flushable, and they don't damage the water supply. So when I got that note from the person who works for me, I picked up my 6 hydrocodone 5 milligram tablets and dumped them down the toilet, knowing that that's safe. Comments or questions?
So let me just throw this out there. The reason you all are here is because you're integral to this whole discussion. And so as we build workflows around doing a PHQ-9 screen or doing, one of these, one of these pain assessment tools, that's got to be built into our workflow. That when we do our next follow-up appointments, we're going to build a template in Epic that is a pain management, just like we have our TCM template. Danny's building a template now for just a pain management office visit that will have a field for the PEG score, that will have a field for the PHQ-2 score, and so what we'll have is a situation where you all have a workflow that when that person's there for their annual or their 90-day follow-up for pain control, that you're doing the urine drug screen, that you're doing, if it's indicated, that you're doing the screening, so that it's all being done so that we walk in where we can have those conversations with the patients. So it's important to know about this, but it's also know that we have to build a workflow that we all agree is an appropriate workflow. Very much like our pain management clinics do right now. I mean, they have a process that they follow to the detail because they know they've got to cross their T's and dot their I's, legally. But we want to be able to be in the same situation, and I think right now we have some weaknesses that because we don't have the structure, but we'll build the structure.
Thank you very much. Other comments? Thanks, Jeff. The second handout that you have here is for our next visit, and we're not going to review that today. It's worth your looking at because it has some useful information, but it mainly is talking, the big things in here are the tapering and the using other forms of treatment. Now, if you would all take this piece of paper, and we're going to take 5 minutes to do this. We're going to do it pretty fast. Just don't think about this. Just pick a number for every item, at least in the blue area, but you can go down to green, pink, and yellow if you want. In the blue area, these are the services that Courtney and I will be bringing to your practice. And what we'd like each of you to do is to make an assessment from 1 to 5, or, sorry, 0 to 5. You are, well, 1 to 5. 1 means you don't have any protocol, you're not using it consistently, you're not doing it. 3 would be you have a partial protocol, it's being used some of the time, but not regularly. And 5 means you do this every time, all the time, perfectly. Got it? And so just go down this list. Do you do a chronic pain assessment? Give us an assessment, 1 to 5. Multimodal pain plan that involves more than a drug. Patient practice evaluation, or education. Do you have patient education? You do have practice education today. Guideline-based directions, opioid risk assessment, Okay, can you fill it out? Just go down 1 to 5 for each of the things in the blue area. We're going to collect these. Courtney's going to summarize them. Please don't put your name on it. And we're going to see what the group, the whole practice, thinks you're
Two
doing
practices.
now, so that